welcome everybody. This is Simran Verma, third Prof MBBS student, and today we have Dr. Rohan Nathwani, who is a surgery resident. And today's topic is liver tumors. Sir, please enlighten us.
So thank you so much, Simran. So let's begin with the topic. So first we'll begin with the classification. There are two types, that is the benign and malignant. And in most common cause of benign, we have the hemangioma. Then we have the focal nodular hyperplasia, adenoma. Whereas in malignant, we have two things, that is the primary liver cancers, whereas metastasis will be there. So in malignant cases, metastasis is more common. In primary, we have the HCC, that is the hepatocellular carcinoma, fibrolamellar carcinoma, hepatoblastoma, and intrahepatic cholangiocarcinoma. Moving on to the benign conditions. So as I said, hemangioma is the very common benign liver tumor. It's congenital in origin. Usually, as you can see in this picture, it's an encapsulated single. Generally, it is very small, but in the picture, you can see it's a very big hemangioma. And it's an incidental finding. Generally, when you go for any USG whole abdomen, you find this incidental finding. So there is the patient doesn't present with you with hemangiomas. So it is usually asymptomatic. And when you call it a giant hemangioma, when there is a greater than 5 centimeter of size, that's a giant hemangioma. Moving on to diagnosis. So yeah, as I said, in USG and CT scan, you can be very much confirmative. MRI also very high, you can see a high sensitivity area, and we have 95% accuracy, but we generally don't do MRI for this condition. USG is confirmative. And needle aspiration and biopsy are contraindicated. Why? Because what is hemangioma? Hemangioma is basically is irregular blood vessels. So if you prick the blood vessel, there will be a huge amount of bleeding. So you don't do any aspiration or a biopsy in this condition. Complication, as I said, it's made up of blood vessels. So we have the bleeding rupture, thrombosis, DIC, and infection. So basically, it's very much common in children. Thrombosis, when a patient presents you with the thrombosis of the hemangioma, it will mimic like an acute liver abscess. But in liver abscess, it won't subside down. But in this condition, it will subside down 3 to 4 weeks itself. So yeah, we have thrombosis. There after we have DIC and infection. Mortality rate is also around 10% in this condition, but it's not that much common. So treatment, as such, there is no treatment required in asymptomatic cases. And if you want to do a surgery, it should be a large symptomatic and an impending rupture should be present. What are surgeries we can do? Embolization. So as it's a blood vessel, we can have an embolization in this condition, enucleation or anatomical dissection, or usually removal of the liver tumor, and we can have a prior radiotherapy to reduce the size, and then we can do hemihepatectomy in this condition. Generally, don't do anything, but yeah, if it's a very much big, we have to do it. Then next we have focal nodular hyperplasia, FNH. So it's a benign condition. It's also a benign condition, but in this case, we have the normal liver tissue. And etiology we don't know, but yeah, we have totally it's a hyperplasia, but normal liver tissue will be present, more common in young and middle-aged women. And in this picture, you can see there are multiple, but in general, it is a solitary nodules will be present, and it's a classical form. So in classical form, we have a solitary nodule, but in unclassical, like lymphatic FNSH or and hyperplastic with adenomatous FNSH can be present. Moving on. It's also usually asymptomatic and it may cause very much minimal pain if it's present, and rupture complication won't be present in this condition as such. If it's there, it's very rare, that is rupture or bleeding. Diagnosis, yeah, diagnosis, we have two diagnoses here. That is a sulfur colloid liver scan, which is very much diagnosis. So in case of sulfur colloid liver scan, basically we inject a dye, and what we find is a very much specific finding we have. That is a hot spot with a spoke wheel pattern. Then we have the CT. Hypervascular mass with the central scan will be seen in this condition. Moving on to the MRI. MRI, we can find ISO or hypointense lesion can be seen. And in FNSC, we can do this. But in FNSC, we won't find anything because it's a normal structure. So what we'll find is a normal hepatocytes and Kupper cell will be present to the central core. So treatment as such, nothing is required in this case also. Moving on. Hepatic adenoma. In case of hepatic adenoma, we have this is also a solitary nodular lesion. But yeah, in this we have normal hepatocytes. But what we don't have is the portal threads, central vein or bile ducts are not present. So are more common in women because as it is associated with contraceptive hormones. So intake of OCPs are more common in women only, sorry. and it is around middle age group. So when you call it as a adenomatosis, when there is a greater than 10 adenomas are present, then only call it as an adenomatosis and is not related to any OCP intake. So yeah, in this picture you can see it's a well circumcised. It's a liver only, liver specimen. You can see a well circumcised adenomas on both the sides. So generally it won't present. It's also asymptomatic, but yeah, you can have upper abdominal pain sometimes, and it may present with rupture, hemorrhage, or malignant transformation. This is also very rare. So how will you diagnose? We have again USG and CT. MRI we don't do, but yeah, ideally it should do. That's we will have a hyperintense or a hyperintense lesion can be seen. FNSC if required can be done. Then treatment. Treatment as such in this as it is related to OCP use, have to stop OCPs first. So in this case, what we do, we have to just observe for 6 months. For every 6 months for 2 years. If there is no regression or nothing like that, they have to do a surgical excision has to be done. So for 2 years, we have to observe. And if it's adenomatosis, as I said, greater than 10 adenomas, we have to do a hemiheparectomy and transplantation has to be done. So when is a surgery indicated? If there is a severe rupture of adenomas, or there is a very big, large adenoma, then only we will do. Otherwise, you will just observe for 2 years. No CP should be stopped. Malignant liver lesions. Most common primary, we have the hepatocellular carcinoma, HCC. In this case, also male are more common than female. Right lobe is commonly involved. And what are the risk factors? As it is seen in this picture, what the risk factors are basically anything which will cause liver cirrhosis. Like we have hepatitis B, C, aflatoxins, hemochromatosis. Hemochromatosis basically it's a metabolic disorder. Then we can have Wilson's disease. Then alpha antitrypsin deficiency can be a risk factor. Then we have the steroids, alcoholic cirrhosis, we all know. But there is one more thing that is non-alcoholic cirrhosis also. It can be present with that. And then we have the conditions like obesity and diabetes and all that, which will affect and cause cirrhosis. कैमरा को क्या होगा पिक्चर क्लियर है
Yes, sir.
Moving on. Clinical features, yeah, it's mainly the patient will complain of a very much large and large mass will be present. That is on examination. But on symptoms wise, when we see the patient will come to you with a loss of weight, loss of appetite, and there is a severe upper quadrant pain. That is in right hypochondrium. In our symptomatic is not that common. Symptoms will be present. Worsening of the any pre-existing liver disease like hepatitis B or C, acute liver failure symptoms can be seen. And paraneoplastic syndromes are very much less common. That is 1% of cases you can see with this condition. So on examination, signs of cirrhosis, and as I say, hepatomegaly, it's a very large mass. What are the signs of cirrhosis? Signs of cirrhosis,
Jaundice,
jaundice will be present. Then
uh, yellow in the मतलब pallid होगा, so anemia will be there.
jaundice, yeah. Jaundice, then we have palmar erythema can be present. Then we have caput medusa, that is the veins around the umbilicus. Then we can have spider angioma. There are many things related to cirrhosis of liver. Then moving on. Systemic features. Systemic features related to cirrhosis only, like hyperglycemia, hypoglycemia, because the liver is not functioning. So all the functions of liver that is the toxicity or the gluconeogenesis all will be hampered. So we will have hypercalcemia, hyperglycemia, hyperlipidemia, hyperthyroidism, also erythrocytosis. Because RBCs are synthesis in the children. So yeah, then spread of a tumor, basically it's a lymphatic blood and direct infiltration. So direct infiltration is to the diaphragm and the neighboring structures. Blood, it's lungs, bone, adrenal glands, and lymphatics is to the more common that is other parts of the liver or the lymph nodes by that it will spread. Diagnosis. The most important diagnosis is a tumor marker, that is the AFP. It should be greater than 100 nanogram per ml. Others also we have like DCP, Lipsian 3. But yeah, but AFP is very much important. It begins to rise once vascular invasion by tumor starts. Hence, it is insensitive. In case of basically, it is telling that in case of early tumors, it won't detect because only AFP will rise when there is a vascular invasion or the blood vessel will be invaded, then only. So AFP won't be detected in the early cases. But yeah, it's a very much diagnostic pattern. Then we have ultrasound, CECT, and it's a very ideal and reliable condition. Ideal and reliable. MRI, then CECT, we have contrast MRI also we have. Then we have the lipoidal CT, which is gold standard, but is not practiced commonly these days. Then biopsy can be done, laparoscopic evaluation and ultrasound is not done, but yeah, you can do with that also. And FDG PET scan and bone scan basically is for metastasis. In the whole body, you can see where all it is the metastasis is there. PET scan is basically it will check the metabolic activity of any area. So if there is any tumor or there is a high metabolic area, that can be checked by PET scan. Then we have there are many classification for FCC, like so this is BCLA, that is the Barcelona clinic we have. Then we have the TNM also we have the OCUDA. There are many classifications, but yeah, it's a BCLC and TNM is very common. BCLC Barcelona Clinic Liver Cancer Staging System. It's a better than TNM staging. Yeah. So I will not discuss the whole thing, but yeah, I'll just tell you about it. The stage there are stage from 0 to D. It is a 0, A, B, C, and D. It is there because it deals with the prognostic factors and the nodules, it is single or multiple, and when it is required. Really, when we require a resection or when we require a transplantation or any embolization or the drug like we have the sorafenib, it's in very much advanced stage we use sorafenib, chemotherapy. And last is very supportive, the in terminal stage we use supportive therapy. So it will basically tell you the prognosis and how much the patient survival rate will be there in this. And then we have the TNM staging. TNM staging is a very old staging. We have the T, N, and M. TMM, T basically is the tumor size, and N is we know it's the lymph nodes, and M is metastasis. M is very simple, M0 or M1, that is metastasis is there or not. So in primary tumor is again I'll not discuss much, but yeah, it is T1A, T1B, depending on the size, that is less than 2 centimeter, greater than 2 centimeter vascular invasion and all that. Then we have the solitary tumor, multifocal tumors at T3, T4, and NH is not SS, N0 is no lymph node metastasis, and N1 we have the lymph node metastasis. Really, we do the staging with this all 1A, 1B, 2, 1C. With all the staging, we can get how we have to proceed. The surgery is the choice, or chemotherapy or radiotherapy is the choice. You have to check by your TNM staging only. Moving on. Treatment. Treatment, we have a definitive treatment, that is the hemihepatic this is the removal of the segment of that area. So in hemihepatic it is very much limited to one lobe. Treatment of choice for an operable HCC non-cirrhotic, but it's a non-cirrhotic, then you can do. Because in non-cirrhotic patient, there is chances of liver regrowth. But in case of cirrhotic, there is no chance of liver regrowth. So you have to do a proto transplantation. So yeah, total hepatectomy with orthotopic liver transplantation in case of cirrhotic patients. Because there is no chance of any regeneration. Moving on. Then we have the adjuvant therapy, which will add on only. We have the drugs like the chemotherapy, which is all the sorafenib, levatinib, that is the first line. Then we have the regorafenib, carbonazepam, that is second line drugs. Then systemic chemotherapy, we have the adriamycin, cisplatin, carboplatin, mitomycin, nortrotide, which all you will deal in pharmacology. And new adjuvant chemotherapy add-on. It's already add-on. And then we have the palliative. Palliative, we have the terminal stage of the liver cancer. So what we do, we have the radio frequency ablation, that is RFA. Thermal ablation also we have. Thermal ablation basically 19 gauge needle will put inside that liver tumor and they will give a 500 kilohertz of electric current. So with that electric current, basically that area will be damaged. It's a palliative, is not a curative treatment. And for this ideal situation should be less than 3 centimeters and it should be very much deep in the parenchyma and away from the hilum. Moving on. So yeah, we have the percutaneous ethanol or acetic acid injection. We also have this. It's a very much cheaper if the patient is not willing for it, if the patient is not affordable, we can do. Rule of three is basically in this, it should be less than 3 centimeters. It should be less than three nodules. It should be less than three. So we have the rule of three. Then we have the TAC, that is the trans arterial chemotherapy within the artery. we will go inside and give the chemotherapeutic agents like adriamycin, cisplatin, mitomycin, and the artery that is like produce the gastroduodenal artery. Then we have these are all the palliative we can use or we cannot use. Microwave, we have cryoablation, then we will ligate the hepatic artery. Basically, main artery supply of the liver is the hepatic artery. So if we ligate the hepatic artery, it will the blood supply will not reach the tumor site. Then we have the transarterial 1131 lipoidal, yttrium 90 microspheres, and we have a targeted these are iodine injection. These are our adjuvant after liver resection we can do. Moving on. Liver transplantation. So there are two types of liver transplantation: living and cadaver. Cadaver is after death, after dying. So after death, you can give a liver, that is a whole liver graft, or you can give a reduced or split graft. But in case of living condition, you can give the whole right lobe, or a left lateral segment graft. You can give. Then we have the fibrolamellar carcinoma. This is not that much common, but yeah, it is seen in the young patients and it is equal in both the sexes, whereas hepatocellular carcinoma was more common in males. Left lobe commonly involved, whereas in hepatocellular carcinoma, right lobe was involved. AFP will be normal in this condition. In HCC, AFP was the marker. In this condition, the tumor marker, we have the vitamin B12 binding protein and neurotensin level, which is the tumor marker in this condition. And the diagram you can see it's a metastasis to other areas. In advanced you can see in the lung, peritoneal cavity, and lymph node you can see. But in clinical features, what we have is the primary it's where symptoms will be there, and no biomarker, no risk factors are there. Moving on to the CT scan. CT scan, we have a typical stellate scar with the radial septa showing persistent enhancement can be seen. And whereas in treatment, it's a resection that is a 50 to 75% cases you have to resect it. It is a better prognosis because HCC is like you are dead. Dead means you have to do only palliative or liver transplantation is the only option. Then we have the hepatoblastomas. It occurs within 2 years of life. Most common primary liver tumors, it's in children basically, and male is more common than female. Here also serum AFP will be elevated. CT scan, we have the vascular mass with the speckle calcification. So hepatoblastoma is a condition which is in, I can say, within the very young age. And hemangioma also, we have seen it is a congenital condition, but it's a benign. In this case, it is a malignant case. So it's a very much highly sensitive to chemotherapy. And here also, resection is the initial choice. Liver transplantation is for everything. It's for every malignant condition. But yeah, it's very much expensive. So you can do a resection or anything, ethanol injection you can provide. Secondary liver metastasis. So if you compare between the primary and the secondary is the most common in case of malignant tumor. So what are the causes? We have the abdominal causes. In abdominal, we have anything like any tumors of the abdomen, like colon tumor, cholangiocarcinoma, or anything abdominal tumors which will cause metastasis to the liver. Yes, the abdominal, what we have is the melanoma, CA, breast, lung, bladder, prostate, esophagus. Thoracic esophagus in case of SJ abdominal, whereas in abdominal we have the inter-abdominal esophagus. And testicular, adenoid tumor, follicular carcinoma of thyroid. These are all SJ abdominal which will cause liver metastasis. Moving on, we have one more classification that is a colorectal, neuroendocrine, non-colorectal, and non-neuroendocrine. So it depends on the prognosis. If it is a colorectal metastasis, it's a very good prognosis. We can have resection, chemotherapy, or intra-arterial chemotherapy can be also be given. Whereas in case of neuroendocrine, it's a slow growing hormone controlling therapies, chemotherapy, cytoreduction using liver resection can be done. Whereas non-colorectal and non-neuroendocrine, it's a very much poor. The patient won't survive much, but yeah, we can have chemotherapy and resection in early cases. Route of spread. So what are the routes? We have the portal vein, lymphatics, hepatic artery, and direct. Direct from the stomach, colon, or gallbladder. These are the neighboring structures of the liver. So directly from them we can have bile duct. Then from artery we have the hepatic artery. Melanoma can occur from melanoma to liver. Then we have from portal vein, carcinoid tumors, other GIT malignancy, and lymphatics, unlike breast and lung. So what are the clinical features in this condition? We have the multiple. Generally, what all we see in benign, it's a solitary, but in this case, it is multiple, hard, nodular with umbilication. Umbilication basically it means there will be a necrosis in the area, so you can find a central necrosis. So yeah, jaundice will be present, loss of appetite, weight loss, upper quadrant pain, and yeah, Blummer sign. Blummer self is basically metastatic sign. It is. I will discuss later. It's a rectovesicular secondis, Blummer self. So then we have supraclavicular lymph node enlargement. We have Virchow's node, and we have the clinical features of the primary tumor. So yeah, Blummer self basically I was telling you, it is a digital examination of the vaginal or the parietal examination where you find out metastatic tumors. Moving on. Diagnosis, again, we will have basically get the primary tumor. So if it is a colon or something like that, we have to go gastroscopy, colonoscopy, X-ray, CT scan, whatever we have to find a primary tumor. Then we will go for liver biopsy. Ultrasound is always there. Tumor marker is CE8. And MRI, CT scan, laparoscopic ultrasound are all the new modalities, and it's can be done. Treatment. What are the treatment? Chemotherapy, surgery if required. If it is a primary from colon or kidney, then only we do a surgery, otherwise we don't. If it's a colon, what we will do, we can do a palliative hemicolectomy with hemihepatectomy. If it's a solitary tumor. And palliative surgeries for primaries has to be done. So yeah, hepatic artery ligation or therapeutic embolization with clot or foam. Basically, we have to do embolization so that the hepatic artery is ligated or hepatic artery is not working. Because see, hepatic artery is the only artery which supplies the tumor. So basically, see, then liver, what I just forgot to tell you, in liver, the blood supply is basically from the portal vein and from the hepatic artery. So hepatic artery is the only artery which will supply the tumor. So if you cut away the hepatic artery or ligate the hepatic artery, the liver will still survive because of the portal vein. But yeah, the tumor will not survive. So that's why we do hepatic artery ligation. So thank you so much.
Thank you so much, sir, for running this incredible session. Now I would like to put up some questions regarding the session.
Mm. Yes, sure.
So, firstly, why do men tend to have higher liver cancer rates than women?
So yeah, men tend to have more common HCC as you've seen. Why? Because it's a hypothetical or it's a hypothetical case because there is nothing sure about it. It's a hypothesis that the androgens which are present in males are which causes the carcinoma, whereas the estrogen present in the woman which will prevent the carcinoma. So it's just a hypothesis. There's nothing much surety in that. Yeah.
So, does coffee have any protective measures against the cancer? If yes, so how does it work?
See, coffee, it's also a research process. It's also ongoing research, and the contents of coffee, which we have the mainly caffeine and other things what we have. But yeah, caffeine is as per the WHO criteria, there is 15% less chance of having the cancer with having every cup of coffee per day. But yeah, it's also a hypothetical situation.
So,
Next
what
question.
preventive measures can be taken against liver cancer?
So preventive measures can be taken as the risk factors we have to see for the liver tumors. What are the risk factors? As I show everything for cirrhosis, whatever it will cause cirrhosis like hepatitis B, C. So we have to take the vaccination for hepatitis B. It's for doctors and for nurses. It is much, uh, very much there to have to take the vaccination. And the other things like alcohol, we should not take alcohol. But yeah, I don't know about it. But yeah, we should not take alcohol. Other risk factors like should not have multiple sexual partners or exchange of syringes or use of contraceptive devices. Basically, prevent the risk factors from having.
So, under hepatocellular carcinoma, you talked about two staging systems. Which of them is better, BCLC or TNM?
See, TNM is the old staging and BCLC is the new staging. BCLC is basically it will also tell the prognosis. Prognosis means how much patient will survive and also how much what all treatment plan you have for anything for the stages. So the BCLC is more convenient and more better prognosis we have. We have to can find it out.
So, what is the role of OCPs in hepatic adenoma?
OCP basically, yeah, it's a in the treatment also. I said in hepatic adenoma, OCP should be stopped because OCP will lead to hepatic adenoma. OCP is basically, as I told, the estrogen will prevent. But yeah, in this case, we are preventing the estrogen and the androgen in both the condition. So it will not prevent; it will basically enhance the condition. So yeah, OCP should not be used in this case.
So, under the diagnostic tools of FNH, you discussed about the sulfur colloid liver scan. So, could you elaborate upon it?
Yeah, it's a diagnosis condition in that. Basically, what we do is 99 technetium sulfur chloride we inject in the veins, and what we do, we have the repeated after 30 minutes we do a repeated CT scan. So basically, you have to see you can see the anatomy of that liver as well as the spleen also we can use, but yeah, in this case we are using for liver. So it's very much as I said, there is a hot spot and there is a stellate scar will be present in this condition. So it's a diagnosis feature for this.
Thank you so much, sir, for answering all the queries.
Thank you.